Hello dear students, today the theme of our topic is vertical direction anomalies, open and deep bite, clinical, diagnostic and therapeutic methods. Vertical problems usually manifest as easier and increase or decrease in the incisor overbite. This can range from a small increase or decrease in easier direction to an increased and complete overbite or frank open bite. An increased overbite occurs when the incisors have erupted past each other and is often, also not always, associated with reduced vertical facial proportion. An increased overbite is a common feature of Class 2 Division 2 malocclusion, and its reduction will be necessary to establish a Class 1 incisor relationship. It is much easier to correct an increased overbite in a growing patient because growth of the mandibular condyles can help compensate for any posterior dental extrusion that may be used to facilitate overbite reduction. In addition, correction of the interincisal angle is important for the stability of overbite reduction, as the establishment of an occlusal stop is essential to prevent the incisors from erupting past each other and the overbite increasing again following treatment. This is especially relevant for Class 2 Division 1 cases associated with proclined upper incisors, because unless maxillary incisor inclination is corrected, an occlusal stop will not be established and the overbite will relapse. Management of deep overbite in cases with a low maxillary mandibular planes angle is also made easier with a non-extraction approach. If teeth are extracted as spaces close towards the end of the treatment, overbite control becomes difficult and the incisors will tend to upright, which can lead to overbite deepening again. Before treatment, of course, we have to make some evaluating of the degree of open or deep bite, and in this case we again use cephalometric measurements. The vertical jaw relationship can assess by a number of ways, and one of the most important and common ways is cephalometric evaluation of maxillary mandibular plane angle, MMPA. The MMPA is a common method for evaluating the vertical jaw relationship with this angle with horizontal reference planes that are easily located. The mean value is 27 degrees plus minus 5 degrees. FMPA, Frankfurt mandibular plane angle, use the Frankfurt plane as a horizontal reference to the mandibular plane. These methods ignores the maxillary plane, which, if affected by a significant, can give a misleading value to the vertical jaw relationship. It is useful to use these measurements in conjunction with MMPA, mandibular plane angle. Then we evaluate the height of the face, which is divided in the anterior facial height and posterior facial height. Anterior and posterior facial heights also used as a measure of vertical facial relationships. And first we evaluate the total anterior facial height, TAFH, which extends from point 9 to maintain point with both lines constructed perpendicular to the maxillary plane, and the average mean is 190 millimeters in an adult male. TAFH is further subdivided into upper anterior facial height and lower anterior facial height. Upper anterior face height, UAFH, extends from nasation to maxillary plane, and the average mean of its height is 54 millimeters. Lower anterior face height, LAFH, extends from maxillary plane to menton, and it's about 65 millimeters. And the lower anterior facial height should be approximately 55% of the total anterior facial height. Then we evaluate the total posterior face height, which extends from sella to point gonion, with both lines constructed perpendicular to the maxillary plane. And maxillary plane goes through anterior nasal spine through posterior nasal spine. Upper posterior face height extends from sella to maxillary plane, and the average mean is about 46 millimeters. Lower posterior face height, LPFH, extends from maxillary plane to gonion, and the mean value is 33 millimeters. The total posterior facial height should be approximately 65% of the total anterior facial height. It should be noted that total posterior facial height, unlike the total anterior facial height, is influenced by a particularly superior or inferior position of sella, and this will affect the ratio posterior facial height to the anterior facial height. Referring to the SN maxillary plane, angle can check the relative position of sella within the cranium. This is ratio of total posterior facial height. Etiology of anterior bite. What is the etiology of anterior open bite? Anterior open bite can be part due to the history of thumb sucking, digit sucking, which had also caused narrowing of the maxillary arch and the posterior crossbite. Sucking habits of children can indulge in a variety of non-nutritive sucking habits during their early year, which in the majority of cases involve the use of dummies or digits. Dummy sucking is more common in the first few years of life, but quite rare beyond the age of 5 years. In contrast, digit sucking is more prevalent in children over 5 years, being seen in around 10% of the population of the world. Both these habits can influence the developing dental arches and occlusion if continued beyond the second year of life, with the severity of the effects being related primarily to the type, frequency, intensity, and duration of habits. And so habit problems can increase the maxillary arch length and prognatism. The etiology factors of the anterior open bite can be transitional, and the permanent incisors are erupting. It proceeds in the early mixed dentation stage. Then it should be secondary pathology of local, secondary to local pathology such as supernumerary tooth, which prevent eruption of the maxillary incisor. Then it could be the secondary to generalized pathologies such as a pure soft tissue tone associated with muscular dystrophy or cerebral palsy, and it could be skeletal. Condition associated with the loss of muscle tone, such as muscular dystrophy and certain types of cerebral palsy, result in downward and backward rotation of the mandible, an increased lower face height and anterior open bite. Adults with increased anterior face height have reduced bite force and also different composition of muscle fibers in the masseter, which implicates muscles as a primary cause of malocclusion. However, in children with similar skeletal makeup, the bite force is the same as children with normal face height, implying that the loss in force may develop with this opposite to causing a malocclusion. The patient also can present with a hyperdivergent skeletal pattern and an increased maxillary mandibular planes angle, indicating that a skeletal element was also involved. Mouth breathing, children also is one of the etiological factors of open bite. Children with nasopharyngeal obstruction associated with enlarged adenoids have been shown to have longer face and smaller mandibles compared to controls. Neonates by necessity are nasal breathers to allow sucking, but most pre-adolescent children adopt a posture with their lips habitually apart at rest. This results in many cases due to greater vertical growth of the lips compared to the lower facial skeleton, particularly in boys. Total experimental obstruction of the nasal airway in primates and humans result in a change of head posture, with the neck being extended and a downward and backward growth rotation of the mandible occurring. Following adenoectomy for children with severe nasopharyngeal obstruction, a greater horizontal rather than the vertical growth pattern has been described. In humans, total obstruction of the nasal airway is rare, and many children, even with some nasal blockage and lip incompetence, do breathe through their noses. It is therefore impossible to generalize on a normal population using data gathered from extremes. The question still remains whether partial nasal blockage is an etiological factor in malocclusion, as the situation appears more complex than a simple form-function interactions. When we plan the treatment of open bites, of anterior open bites, it is important to establish etiology first. In the presence of an anterior open bite, the tongue will come forwards between the incisors to fill the gap and create an anterior seal during swallowing. For many years, it was thought that this tongue activity or tongue thrust was the primary etiological factors in the development of anterior open bite. It is now recognized that in the vast majority of cases, this is an adapted behavior. If the main etiological factor is a digit sucking habit, as long as this ceases at an appropriate time, there can be complete and stable resolution of the anterior open bite. The main problem arises with anterior open bites that are skeletal original. So treatment of open bite depends in which stages of the occlusion development we started the treatment. In primary dentition, it is reported that 50% of 3-year-old children have anterior open bite. However, a large amount of these open bites self-correct as the sucking habits cease, and thus about 4% of school children and adolescents show open bite. Morphologically, open bite can be categorized as being of dentoalveolar or skeletal origin. The dentoalveolar open bite is usually caused by impaired eruption of anterior maxillary or mandibular teeth together with deficient vertical development of the alveolar process. In skeletal open bite, a high-angle hyperdivergent mandibular plane related to the cranial base is evident, implying an increased anterior face height that is associated by a backward or posterior growth rotation of the mandible. In skeletal open bite cases, the prognosis for stable treatment results in highly dependent on the remaining growth. Therefore, the treatment is often postponed until the growth has terminated. The skeletal open bite is mostly of hereditary origin, but environmental factors can contribute to open bite. Among them are sucking habits, tongue thrust, and breathing deficiency to the obstructive pharyngeal airways. The obstructions may be caused by large adenoids and tonsils or swollen mucosa due to the allergies. In addition, changes in muscle function associated with an extended head posture, as well as prolonged obstruction of nose breathing, can contribute to the further development of skeletal open bite. If you are talking about treatment in primary and mixed dentition stage, also it should be reasoned and based on functional and aesthetic reasons. In primary and early mixed dentition, the focus is on breaking the sucking habits. If the sucking habits terminate at 6 to 7 years of age, the prospect is good for self-correction of the open bite. On the other hand, if the sucking habit has not terminated by this age and the child is psychologically motivated for treatment, treatment can be accomplished with a lingual arch or a removable acrylic plate with a crib. The crib will prevent the child from sucking the finger of thumb, as well as prevent the tongue being forced in between the maxillary and mandibular incisors during swallowing. The crib may be perceived as bulky or uncomfortable, but it is remarkably well tolerated by most children. If the appliance contributes to breaking the sucking habit, it is advisable to continue the treatment for a further half a year to prevent relapse of the habit. However, if the sucking habit still does not cease despite treatment, it may be appropriate in these rare cases to refer the child to a child psychologist for evaluation of whether the habit is symptom of a psychological disturbance. When respiratory obstruction is evident and suspected to be the cause of the open bite, an ear, nose, and throat specialist should be consulted to consider whether, for example, large adenoids or tonsils are apparent, and if so, whether adenoidectomy or tonsillectomy is recommended to remove the respiratory obstruction. Here we can see the use of the creep for preventing tongue thrusting and thumb sucking. The transpalatal bar soldered to bands of the maxillary first molars or mandibular or maxillary first molars, and they shall be at 6 to 8 millimeter space between the bar and palatal mucosa, allowing for instruction of the molars by pressure of the tongue when swallowing. Also, we see here removable appliance with a vertical creep, as you see here, important to make creep long enough to be an obstacle for the tongue. Sometimes treatment intrusion effect can also be further increased if a high pull headgear is combined with a transpalatal bar. A number of pathological conditions can contribute directly to a malocclusion, causing either skeletal discrepancies or more local effect upon the dentition. Here you can see the fracture of the condyle. The condyle is a common site of fracture in the mandible during childhood, and many go undiagnosed. In severe cases with bilateral fracture and dislocation from glenoid fossa, an anterior open bite can be one of the presenting features due to loss in ramus height. A long-term sequela of early trauma to the mandibular condyle can be asymmetry with an ipsilateral decrease in ramus height and deviation of the chin point to the affected size. Here. The severity of outcome in the part related to the age at the time of injury. However, a high percentage of children sustaining a condylar fracture have a normal mandibular growth due to the reparative capacity of the condyle, even when displaced from the glenoid fossa. Also, during open bite, the child encounters with speech problems, and that's why the treatment is very important here, because it's often required because the patient has trouble incising food due to the lack of an anterior occlusion, and because it's associated with lisping. and while treatment can improve both the occlusion and function, there is no guarantee that speech will improve, as speech patterns are established early in life, long before establishment of the permanent dentition. And there are essentially three ways that a skeletal open bite can be treated. Extrusion of the labial segments and anterior bite occurs when the labial dentition at the limits of its eruptive potential. Therefore, any further mechanical eruption or extrusion will be inherently unstable and is not advised unless it is related to a digit-sucking habit which has prevented eruption of the incisor. Occasionally, towards the end of fixed appliance therapy, a small anterior open bite can be resolved and occlusal setting achieved by the short-term use of anterior elastics. Distal tipping of the molar dentition, also used during anterior bite treatment. It has been noted that the buccal dentition, especially the molars, is more upright or mesially angulated in the presence of an anterior open bite. A technique whereby the molars are tipped distally using multi-looped wires with divergent curve of spear built into them has been described by Kim. Heavy anterior elastics are used to stop the anterior open bite getting worse and bring the incisors together and the molars tipped distally. This is further facilitated by removal of terminal molars, and the mandible works on a huge works in a huge or removal of terminal molars which are closer to the hinges should help close down an anterior bite by removing the posterior occlusal contact, as you see here. Vertical control or intrusion. The buccal system segments. This is difficult to achieve with orthodontic tooth movement. The aim is to reduce posterior gentle heights, which will result in a forward rotation of the mandible and closing down of the anterior open bite. Because the molars are closer to the condylar hinge, even a small amount of intrusion should result in a greater closure anteriorly. Numerous techniques that attempt to achieve this have been described. Similarly, any extrusion of the molars will worsen the anterior open bite. It is important to avoid the use of class 2 and class 3 elastics in such cases. If intermaxillary retraction is required, the elastic should be short and not run to the molars. In a growing child, the use of high pull headgear, especially when there is a skeletal class 2 base relationship, will control posterior vertical growth of the maxilla. This will theoretically redirect mandibular growth in a more anterior than vertical direction. The headgear can be run directly easier to bands on the upper first molars to a removable appliance with posterior capping intrusion split. Headgear can also be used in combination with a functional appliance to try and correct an increase over jet when there is a reduced overbite and a vertical growth pattern. The main problem with the approach is that vertical growth continues throughout adolescence, and therefore to be truly effective, headgear will have to be worn until adolescent growth has stopped. In adults, growth will have essentially ceased. Therefore, treatment of an anterior open bite will necessitate intrusion of buccal system segments. Also, implants and microscrews potentially provide an exciting new way of achieving this, as present the most predictable and stable way of correcting an anterior open bite in an adult is by surgical impaction of the maxilla. This will reduce the posterior dental height, allowing the mandible to out-rotate and close the anterior open bite. But about it we will discuss in our 5th lecture, because it's regarding the surgical treatment of dental alveolar malocclusion. Tick bite is one of the most common